Hello everyone, I'm Dr. Krutarth Pandya and I'm soon to become internal medicine resident at Trumbull Regional Hospital in Ohio, USA. And as I've always been interested in cardiology have been my topic of interest, and I have done multiple rotations in USA and India. And here I'm presenting you my topic on infectious disease in cardiology, and I am glad that I have got this opportunity to present myself at Global Congress on Infectious Disease and HIV/AIDS. Thank you. Let's begin with my topic.
Hi, hello everyone. This is Krutarth Pandya, and we'll begin with the understanding infections affecting the cardiovascular system. And I would like to start with a case which I saw during my rotation at Mount Sinai Hospital in Manhattan, New York. A 60-year-old male presented to the emergency department, referred from his primary care physician for complete heart block with 43 heart rate of 43, and he was relatively asymptomatic, and he was referred for pacemaker implantation. That's what the note was from his primary care physician. History: he had flu-like illness since last 1 week with plus or minus fevers and chills and weakness, and one episode of vomiting and diarrhea. Among family history, his mother had hemorrhagic stroke and father had rheumatic fever, multiple MIs, the first one being in 30s. On examination, he had systolic murmur of 2/6 and WBC on initial labs were 17 points. So looking at the scenario which he presented, we thought about the infectious etiology which could cause the complete heart block. So we ordered Lyme disease serology, which came negative. We meanwhile took the blood cultures and everything. Meanwhile, he called of having bicuspid aortic valve, which one of his physician told him after an echocardiogram few years back. So we went for TGE, which was inconclusive, followed by TEE, which showed unexpectedly aortic root abscess with endocarditis. So that was somewhat huge abscess, I can say, about 1 or 1.5 centimeter in size, and we all know it's just aortic root is near the AV node, so hence it could affect that, and it was causing the complete heart block. So he had to go for urgent aortic root reconstruction surgery, basically an open heart surgery, and the culture grew Streptococcus gordoni, and antibiotics were modified accordingly, and eventually the patient did well. So that's the beauty of medicine. I mean, we have to just dig in and ultimately we reach the diagnosis. So you have to just keep your mind broad and think about how it goes. So that was one of the interesting case, and we'll move ahead with that topic only, the infective endocarditis. Introduction. Okay, so now we can classify it accordingly, like natural versus iatrogenic. We can also classify it as one of the type is infective endocarditis, the other is perimyocarditis, the other one is device associated infection, which is definitely somewhere part of iatrogenic infection. So we can also subclassify the infective endocarditis into different categories, and which are somewhere prone in different regions. Like in developing countries, you can find more of chronic rheumatic heart diseases. In developed countries, you can find IV drug use associated degenerative valve diseases and intracardiac devices associated and infective endocarditis, and congenital heart disease related infective endocarditis are somewhere common in both developed countries. Talking about etiologies, the more common etiologies are streptococci and the staphylococci. Staphylococci being the more virulent one. We can mainly find that among the injection drug users. We all know they use, I mean, without any sterilization or anything, they inject drugs. And the staphylococcal, we all know, being the common flora of skin, which can be penetrated and it can reach the right heart. So we can see here more of the cases among the right heart endocarditis having the Staph aureus. So also it can reach to lungs and followed by left heart, but it's somewhere less common than the right side. We can also find Staph aureus infection on the native wall endocarditis, being it the more virulent one. We can also find coagulase negative staphylococci, more prevalent among the prosthetic wall endocarditis. And talking about strep, it's more common in native wall endocarditis, while also it is more common as whenever there is community acquired infection over the healthcare associated, where healthcare associated it's the Staph aureus more common. So that's how the etiology can be. Pathogenesis. Talking about pathogenesis, then mainly there is endothelial injury, which exposes the endothelium to the blood, and if there is transient bacteremia, it can easily lodge there. If there is no transient bacteremia right there, then also there can be a thrombus formation. It can cause inflammation and endocarditis, that is NBTE somewhere. Other etiologies which can contribute to the infective endocarditis are MRAS, AR, and VSD. Those are the diseases which can misdirect the blood jet in the heart somewhere, and which can create a situation where endothelium which can be damaged due to that abnormal blood jet, and hence can cause endothelial injury and followed by endocarditis. So that's how the pathogenesis work. One interesting type is melantic endocarditis, which is related to the hypercoagulable state like malignancy and chronic diseases. Here what happens that in this condition, hypercoagulable state, there is high chances of thrombus formation, and which follows this ultimately this mechanism. So that's how it can complicate SLE and APLA-like syndromes, and phospholipid and SLE systemic lupus syndromes. Clinical manifestations, if we talk about, there are mainly cardiac manifestations. Those are the cardiac murmurs. If there is severe involvement of valves, and if there is regurg and all those things, then patient may have symptoms of heart failure or something like that. There can be peripheral findings. There are a lot of it. I'll show you pictures in the later on slide. Rod spots, ossular nodes, atrial emboli. There are Janvey lesions. Janvey lesions and ossular nodes are somewhere similar, but ossular nodes are painful while these are painless. These are immunologic phenomena, while these have bacterial subcolonies there. So that's the difference. There can be subungual hemorrhages below the nails. There can be non-specific chronic disease findings like night sweats and fevers and weight loss and weakness and stuff like that, non-specific. Okay, so next is the immune complex phenomena. As I said, the ossular node is one of the immunologic phenomena, and these are the immune complex phenomena like arthritis, glomerulonephritis, rheumatoid factor can be found positive in those patients. That's something we have to keep in mind. Okay, these are the pictures of conjunctival petechiae, splinter hemorrhages, Janvey lesions, and ossular nodes. This can be pretty much similar when we try to look at it, but these are painful, these are painless, these are immunologic, these are having the subcolonies of bacteria. These are the retinal findings, rod spots, and clubbing can be just in general found in any chronic heart or lung diseases. So, and this is the mechanism. If MVP is there, then it can patient can be prone to infective endocarditis. If patient is having bicuspid aortic valve, that like just our patient had, then also he can be prone to. IV drug users are prone to. This is the mechanism how this is the vegetation and how it forms. This is the biofilm by the bacteria, and that's how the vegetation is formed. So next, moving to the diagnostic part, then this is very important, Duke's criteria. So there are major criteria, minor criteria to diagnose the infective endocarditis. Among the major criteria, there are blood cultures, two separate blood cultures to be drawn, and coxilla serology. There is 1 gem 800, should be more than that if you're suspecting coxilla serology, coxilla burnetii. There should be a specific evidence for endocardial and involvement with the echocardiogram. There should be a vegetation or adhesion abscess, something like that. There should be evidence of new valvular regurgitation. Those are the major criteria to diagnose. Among the minor criteria, there is fever, vascular phenomena as we described ahead, immunologic phenomena as we described, blood cultures that are not meeting the major criteria, but yet if they are positive, then they can fall in the minor criteria. And to definitively diagnose the infective endocarditis, you need two major or one major plus three minor or five minor criteria. And to diagnose that it can be possibly an infective endocarditis case, then there should be one major at least plus one minor or three minor criteria. So that's how you diagnose with Duke's criteria. This is the echocardiogram finding. Like this is a four-chamber view, ventricles and atrias, and these are the valves. There's a mitral valve, and this is the vegetation. So that's how we diagnose on the this is the treatment. Like it varies depending on the organism. As I said, mainly there are streptococcus and staphylococcus. So we'll see that. Okay, when it comes to streptococcus, then there are susceptible bacteria, there are resistant bacteria. We usually go for penicillin or ceftriaxone or something like that. Unless it is resistant, then we go for vancomycin, or we add gentamicin simply whenever we are suspecting, there is an option. We can go for gentamicin. There are different criteria, and this is the chart. This is a table from Harrison's guidelines. And staph aureus, again, there are sensitive bacteria, there are resistant bacteria. Here also there is a penicillin group of drugs, but different kind of penicillin. There is napsylin, oxacillin, and those are the medicines we use. But if we suspect the resistant bacteria, then we have to go for vancomycin. And if there is prosthetic wall involvement, then we have to add gentamicin and rifampin again, as we have mentioned here. If there is prosthetic wall and sensitive, then again napsylin, oxacillin. If it is resistant, then vancomycin in addition to gentamicin and rifampicin. That's how we treat us. If there is enterococci, then again penicillin, ampicillin, those are the drugs in option, vancomycin and ampicillin. And if there is HSEC group, there is ceftriaxone. For Coxiella burnetis, doxycycline plus hydroxychloroquine, penicillin. Okay, so there is Bartonella species, ceftriaxone or ampicillin. It's just the guideline we have to follow. I mean, it's just day-to-day practice which we can easily remember with. No need worry much about that. Gentamicin is somewhere we can add in Bartonella. Okay, so talking about surgical approach, there are some specific indications where we have to intervene for the patient in addition to the antibiotics. To begin with, if there is a more than 10 mm vegetation plus aortic or mitral valve dysfunction, if there is progressive paravalvular prosthetic regurgitation, if there is valve dysfunction plus persisting infection even after antibiotic for more than 7 to 10 days, or if there is fungal endocarditis, because they are relatively big enough, so they are the patients who need surgical intervention. There are a few cases who need urgent surgical intervention, like if the patient is having heart failure of class 3 or class 4, if there is septal perforation, unstable prosthesis, wall obstruction by vegetation, or perivalvular extension of the infection, like our patient who had abscess, or there are lack of effective antibiotic therapies. Those are the indications where we can go for urgent within a day or two surgical approach. There are a few cases if there is a rupture or something, then we have to intervene immediately. So those are the guidelines for surgical. Moving to the prophylaxis part. So these are the indications where we use the prophylaxis. There are prosthetic heart valves or prior endocarditis or unrepaired or partially repaired or recently repaired and congenital heart diseases within last 6 months. Those are the indications. Or if the patient had valvulopathy developing after the cardiac transplantation, so those are the indications we use the prophylaxis. And this is very important somewhere to note that prophylaxis is no longer required for acquired valvular diseases, bicuspid aortic valve, and MVP with regurgitation. So that's something we have to keep in mind. Okay, so these are the medications we use. Amoxicillin when the patient can take oral medicine. If the patient is allergic, then clarithromycin or azithromycin. If the patient cannot take oral medicine, then ampicillin. If the patient is allergic and can't take oral, then cefazolin or ceftriaxone. That's the approach. Other infections, these are some other infections like rheumatic carditis, which causes indirect damage. Pericarditis can cause direct damage, like in malignancy or something. Viral myocarditis, direct plus immunologic phenomena. Chagas disease, earlier it is immunologic, later on there is earlier there is direct, and later on there is immunologic phenomena. Diphtheria, indirect toxin mediated toxin myocarditis, again bacterial, infective, and ICD, that causes direct damage, including for infective and ICD and all. There is biofilm formation. Here are some other bacteria and diagnostic procedures and proposed treatment for the same. We are not gonna go in much detail. I mean, there is a lot more to discuss about this. These are some rare causes and some labs, and these are the medicines, which mainly includes doxycycline for most. So that's how we approach. Okay, this is important, the hot topic nowadays, COVID-19 and heart. So talking about to begin with the mechanisms by which the cardiac damage is occurred by the COVID-19, and there is SIRS like SIRS. There is systemic inflammatory response syndrome. By two mechanisms it can affect the heart: through cytokines and immune complexes that damages the heart and other end organ damages. oxygen supply demand ischemia. Like we all know that pulmonary damage is there in the COVID-19. So in that case, what happens that pulmonary parenchyma is damaged. So the oxygen which should come through the air in the body, that is decreased. So supply is decreased, and demand somewhere increases because of the labored breathing and all those things. So ultimately, oxygen supply demand ischemia occurs, and there is damage to the cardiac tissue. ACE mediated damage is something interesting to understand. We somewhere know that COVID-19 penetrates the human body in the lungs primarily through the ACE2 receptors. Those are the receptors primarily in the lungs, but they are also there in the heart and the kidney and gut and liver. So those are the organs which are damaged by COVID-19 through direct damage as well as the RAS activation. RAS is the renin-angiotensin-aldosterone system. ACE is the part of RAS system. So if they are destroying the ACE receptors, then the ACE works somewhere in RAS, like it uh, degrades the 82 that is a part of RAS. Like if the 82 is not gonna be degraded, then 82 will be increased, that is angiotensin 2, and eventually it will cause more and more RAS hyperactivation, which will lead to ultimately increased blood pressure and more workload for the heart and system. So eventually it can damage the cardiovascular system. That's how it damages. There can be also cardiac microvascular damage, like as I said in RAS, in SIRS, there are increased cytokines IL-1, IL-6 and D dimers and whatnot. So those kind of things increases the coagulability and hence can create DIC like scenario, that is the disseminated intravascular coagulation, and which can cause microvascular damage in the cardiac vessels, and hence can cause the eventually whole cardiovascular system shutdown. Okay, so this is important to understand. The data so far we have got from the world, I have just narrated here. There was a study in Wuhan, China in February that showed that about 20% of patients, according to that study, were having cardiac injury, some sort of cardiac injury, and most of them were not having any kind of chest pain or prior history of heart disease. So this is important to understand. Cardiac troponin levels somehow correlate with the other inflammatory markers. They increase altogether, and when they are increased, that correlates with the increased mortality. So that somewhere predicts the mortality in patients. So that's also important to keep in mind, though experts don't recommend to go for routine drops or any other inflammatory markers just to predict mortality, because it increases more burden on the labs and more exposure and stuff like that. So cardiac injury was found to be second greatest indicator of mortality after the ARDS. So this is also important according to an article in JAMA by Dr. Shi from China. Other thing is end organ damage usually presents late in the course, around the 14th day, according to a study in Lancet 2020. And COVID-19 can also present, this is important, there was a case presented in JAMA Cardiology in March, that COVID-19 case, there was a female around in 50s, 53-year-old I think so, and she presented with hypotension and cardiogenic shock findings, and on cardiac MRI it showed myocarditis, but the patient was not having any classic dyspnea or chest pain, yet the patient came positive for COVID-19. So this is important to keep in mind. The COVID-19 can present without any classic dyspnea or chest pain, and it can directly show the cardiac damage and those kind of presentation. This was presented in JAMA Cardiology. Elevated baseline troponin shows increased incidence of specifically VT-VF. Those are the ventricular tachycardias and ventricular fibrillations. Those are the arrhythmias which can lead to ultimately arrest and death, and those are the arrhythmias which are most important cause of death whenever it comes to cardiac damage and cardiac etiologies. So that's something we have to keep in mind, like keep the patient away from arrhythmic drugs or those kind of things. If the patient's tropo is high and something like that, we have to just keep them on Holter monitoring. I mean, somewhere we have to just not Holter, but yeah, in ICU we have to just keep something monitor about that patient. So that's how we go ahead with. Okay, this is important to understand. Who comments on NSAID use? This is just the guideline came yesterday. Who declared after 70? They just did a meta-analysis on 73 studies, which included the studies on SARS, studies on MERS, the data which WHO had all over the worldwide, and including the COVID-19 studies. So that's how WHO progressed, and within a month, in March and April, they just came to a conclusion that based on this much data, they have not found any severe adverse events, acute health care utilization, long-term survivals, or quality of life there is no difference in quality of life in patients with COVID-19 as a result of use of NSAIDs. So this is important to understand. There was a controversy and so many concerns and discussions going on about NSAIDs use and aspirin use and in COVID-19 positive or negative patients, but this is what WHO has recommended recently on 19 WHO has recommended on 19th April recently. So this is important, you have to just keep in mind, and physicians can just move further with the NSAIDs as they have been using till now. Okay, moving to next, American College of Cardiology, they issued a guideline on 18 March recently. They mentioned that clinicals are advised to only measure troponin if the diagnosis of acute MI is considered on clinical grounds. Then and then only. Don't go for random drops if you're not suspecting MI on clinical grounds. It just increases the lab burden and exposure and whatnot. So they are just saying that if you're suspending clinical grounds, then only go for drops, and then only it can give you some it can help you to reach a diagnosis. Otherwise, it's useless. So that's the recommendation. Use of echocardiography and coronary angiography. They have recommended to use these measures, echocardiography and angiography, only if in whom these procedures would be expected to meaningfully affect outcome. This is important to understand. They have just issued these guidelines looking at the decrease the exposure and those kind of thing. So they have advised to restrict those patients, and no data exists to suggest the benefit from antiplatelet or anticoagulant therapy for those with acute myocardial injury. Keep it, this is important to understand. Acute myocardial injury due to COVID, with exception of those with type 1 MI. Only if there is type 1 MI, which is a classic MI which occludes the cardiac vessel and stuff like that, then and then only antiplatelet anticoagulant is helpful. Otherwise, if there is direct myocardial injury, it doesn't make sense to use antiplatelet or anticoagulant therapy. So that's the advice from American College of Cardiology as of March. Moving to next, this is the standard scenario how the COVID presents. Initially there is a viral response phase followed by host inflammatory response phase. Initially you have to think when the virus is working on our body, and later on our immune system is working overworking to kill the virus. So there are three stages: early infection, pulmonary phase, and hyperinflammatory phase. Initially there is dry cough and diarrhea and headache and mild constitutional symptoms. Later on there is pulmonary symptoms, and after that followed by end organ damages. Initially we target on reducing the immunosuppression, like we have to keep our immunity higher so that we can fight the viruses, but later on we are focusing on decreasing our immune response just so that we can decrease the hyper inflammation and our own response system that actually causes the end organ damage rather than the virus. So we have to focus on that afterwards. And remdesivir has recently shown some promising results. Chloroquine, hydroxychloroquine, and plasma transfusions, those are the treatments we use right now. Those are the current guidelines for COVID. Expert suggestions about ACE and ARBs. This is also one of the important topic which is right now going on in a lot of discussions, and experts are talking about this. But as of now, there is no data which says either beneficial or harmful effects of ACE or ARBs in COVID positive or negative patients. So experts recommend don't just start or stop ACE or ARBs based on the current scenario. Just use it as you have been using. Don't switch blindly to diuretics and keep the patient at risk for those ionic imbalances and more lab tests and stuff like that. So that's gonna just complicate the things. So experts just recommend just keep as it is until we get the enough data. But meanwhile they are predicting that can be biphasic effect. Like initially when the patient is on ACE or ARBs, the number of receptors are going to be more. So initially it can be harmful, that virus has more receptors to work on and to enter the body. But later on, once the virus has destroyed the receptors, then in later phase, if the patient is on ACE or ARBs, the number of receptors will be more because of the ACE and ARBs. So that can be somewhere helpful to maintain our RAS system, renin angiotensin aldosterone system. So it's just an assumption and theory going on right now, but lots of research needs to be done, and just experts suggest just wait for a while and see how it goes. Till then, just continue A's and F's rather than creating a panic and changing the medicines. Other than that, you just use PPE and follow the guidelines from international bodies and association and WHO and all those bodies, and just local guidelines, and stay updated. These are the references. Okay, this is important for some of you. If you don't know this, this is international flag of planet Earth, which says that 7 rings and 7 continents, and we are united. So that's what needed right now to stay strong, to stay united, to stay safe, and we'll all come out from this together. Hope you like it.